Hello, I'm presenting the case study that is the Alzheimer's disease. The disorder is Alzheimer dementia. My name is Paulson Elekuru. Patient case introduction. The chief complaint is I got lost in the grocery store and my children think that I need those diapers that old people have to wear. The history of present illness. The HPI. Harem is an 83-year-old woman who present to the care clinic for a regular checkup and in company of her two oldest daughters. The patient was diagnosed with presumed Alzheimer disease 9 years ago. Was related to a report of short-term memory loss and several cognitive symptoms. The family observed that she was frequently mislaying her glasses, keys, and hearing aids, and had put several household items in odd places, like placing coffee pot in the refrigerator. Moreover, she took a walk in her neighborhood of 45 years and got lost, with neighbors helping her back home on several occasions. This was the period her children and friends noted some personality changes. She had turned out to be very quiet, inactive, and apparently showed some lack of pleasure or interest in activities she used to enjoy, including flower gardening. A comprehensive clinical workup, including neuroimaging studies, showed no remarkable clinical conditions responsible for her current neurological symptoms. Notwithstanding, she had only 25 out of 30 points on a Folstein mini mental state examination, which was normal. She was prescribed tacrine initially and was then switched to donepezil due to side effects such as nausea, vomiting, and abdominal pain, which has significant positive effect on her memory and mood for some 4 years for some years. 4 years ago, our family members discovered her worsening previous symptoms, as well as the development of new traits of Alzheimer's disease. She began struggling with numbers, unable to balance her checkbook, and forgot how to play bridge, which she had enjoyed for over 60 years. She displayed signs of poor decision making. For instance, she left home without coat or shoes on a cold winter morning. Another time, she went to store in her nightgown. One time, she was fortunate that her neighbor was visiting when a small fire erupted from the kitchen and she forgot to turn off her stove. Afterwards, she had another checkup for systemic disease in which she had only a diagnosis of mild iron deficiency anemia. A CT scan showed moderate to severe bilateral cerebral atrophy of her parietal and temporal lobes. By then, her score in the first 10 mini mental state examination score had decreased significantly to 18 over 30 from 25 over 30. So our eldest daughter sold her house and moved her into her home with her family, and the two oldest daughters shared caregiving responsibilities with our youngest son, helping significantly with her well-being and safety. Within the last 6 months, she showed some level of angry outbursts. While grocery shopping with her second oldest daughter, the patient was confused and got lost and found getting angry and violent when customers and store workers tried to help her. She threw several tomatoes at the store manager before calming down and then got angry again when the grapes she picked fell out of the bag. Over the past 2 weeks, she has been incontinent of urine. Current, Currently, care custody of their mother is becoming strenuous, and the children are deliberating placing her in a long-term nursing care facility. Alzheimer, dementia, description and epidemiology. Alzheimer's disease, AD, is a neurodegenerative disease with subtle onset and gradual deterioration of both cognitive and behavioral functioning, which includes memory, language, comprehension, reasoning, attention, and judgment. In the United States, it is the sixth leading cause of death. AD, which mostly originates from the entorhinal cortex of the hippocampus is caused by neuronal death and is characteristically an old age disease. Globally, the prevalence of Alzheimer's dementia is said to be upward of 24 million people worldwide, with the projection of four-fold increase by 2050. According to Kuma South 2022, over 6 million Americans live with Alzheimer's, with the prediction of close to 30 million by year 2050. One of three older people die of Alzheimer's or other types of dementia, which shows a higher mortality rate than prostate cancer and breast cancer combined. In 2023, about 6.7 million Americans aged 65 years and older were living with Alzheimer's dementia, in which 73% were aged 75 or older. It is about twice more likely to occur in Blacks and Hispanic Americans. The lifetime risk for Alzheimer's by age 45 is 1 in 10 for men and 1 in 5 for women. According to Alzheimer's Association 2023, risk factors include genetics play a critical role in the risk factors identified for both early and late onset. Trisomy 21, an increased level of homocysteine and presence of APOE eta 4 allele are associated with early onset Alzheimer's disease. Others include advancing age, which is the most important, TBI, depression, cardiovascular disease, and cerebrovascular disease, smoking, hereditary, older parental age. Risk reduction factors include use of estrogen by women, higher education, use of anti-inflammatory agents, healthy diet, leisure activities such as reading or playing musical instruments, and regular aerobic exercise. Pathophysiology of Alzheimer's dementia at cellular level. The pathologic features of AD are the aggregation or accumulation of extracellular amyloid B, A beta plaques, and intraneuronal neurofibrillary tangles. The hypothesis of the amyloid cascade. It suggests that the cause of the buildup of A beta plaques is due to the mismatch between A beta synthesis and recycling. The most robust evidence supporting the role of A beta pathogenesis in Alzheimer's disease or Alzheimer's dementia emerged from studies on autosomal dominant Alzheimer's disease, in which the mutation in one of the three different genes, the APP, the presenilin 1 PSEN1 and presenilin 2 PSEN2, resulted in excessive synthesis and accumulation of A beta, subsequently leading to early onset Alzheimer's disease between people, especially people of 30 to 50 years old. While ApoE, a vulnerable gene, is most discovered in random Alzheimer's disease, the APP and PSEN genes mutations, they are correlated with early onset AD. Neurofibrillary tangles developed from phosphorylated p-tau proteins are one of the basic or characteristic features of AD. The hyperphosphorylation of tau proteins resulting in microtubule disruption is typically considered as the primary process behind the ensuing neurodegenerative damage, leading to microglia activation, synaptic loss, and neuronal death. Generally, based on the Braak system, tau pathology emanating from the temporal cortices and tau instead of alpha beta is considered as the major factor responsible for the brain atrophy, cognitive changes, and clinical decline in patients with Alzheimer's disease. Dementia with Lewy bodies, DLB, is pathologically typified by the aggregation of the synaptic protein after alpha-synuclein into Lewy bodies and Lewy neurites in the brain and can be classified as limbic or transitional and diffuse neocortical or brainstem predominant dementia Lewy body. Depending on the pathological spread of the Lewy body, the McCate's criteria, in addition to the four clinical hallmarks of dementia with Lewy body described above, it also includes three additional diagnostic stroke or indicative biomarkers, which are decreased uptake by dopamine transporter DAT in the basal ganglia, proof of REM sleep with absence of atonia on polysomnography test, and an abnormal myocardial scan for benzylguanidine (MIBG), according to Chin and Kumar and Tosau. Clinical manifestation: chief complaint as detailed above. The history of present illness also as detailed above. A past health history: 20 years ago she had hypertension, and 2 years ago she had a nephrolithiasis. The stone passed without intervention. It was mainly uric acid. 2 years ago she had gout. uh, 6 months ago, she had hypercholesterolemia, and 6 months ago, plantar fasciitis of lead foot. Occasionally, she has constipation. The family history: father died from cardiovascular accident, mother developed Alzheimer disease in her 70s. She's also dead. Brother died from heart disease. Sister died 5 years ago at age 76. Also, uh, had Alzheimer disease. Social history: she's a widow of a 14-year husband, died of cancer. Uh, she lives with her daughter. She's a non-smoker and non-alcohol user. Allergies include clotrimazole. It causes rash. Medication is denopacin, allopurinol, pravastatin, lisinopril, ibuprofen, and docusate sodium. She takes Ensure as needed. Pertinent objective data: general appearance, she's cooperative, a bit confused, and with no apparent distress. The vital signs are normal. The physical examination: review of system, there's no history of trauma or recent infection. She reports random bladder incontinence, denied chest pain, shortness of breath, uh, denied joint pain, foot pain, or bowel incontinence. The lymph node and neck within normal limit. HEENT within normal limit, except for the fact that she uses dentures. The chest and lungs within normal limit, except that she has kyphosis. The lung is clear. Is cardiac, GIGU, breast and abdomen, they are within normal limit. Musculoskeletal: the skin is pale dry with senile lentigen and poor turgor. Multiple minor ecchymosis on forearms, no other lesion. The left lower extremity and upper extremity, they are within normal limit. She has a tender great toe with movement. Neuro is within normal limit except for positive tactile agnosia. The foster mini mental state examination currently is 9 over 30, from 5 to 18 to 9. Diagnostic and laboratory, there are detailed on the screen. The role of the APRN. The, uh, Under the Christian world view, the APRN plays a critical role in ensuring that the patient with AD has a quality of life and stays safe. The following: referral for physical therapy to design exercise regimen which has been determined to lower the progression of AD, educate the patient and family on medications, lifestyle changes, and carrying out of activities of daily living, and to report worsening symptoms, ensuring there is no polypharmacy, and will monitor side effects and adverse effects of medications. The APR will monitor patient progress and ensure improved quality of life. Also can refer the patient to available community resources and recommend role of caregiver. The APR will assess the patient as adequate, ensure that the patient has adequate support system and taking healthy diet. The APR will ensure that the patient and caregiver cope with the disease. Highlight two risk factors that predispose this patient to multi-infarct dementia. Does multi-infarct dementia manifest in the same manner with a CT scan study like Alzheimer disease? Another number three, are there ways to differentiate Alzheimer disease from clinical depression in geriatric? That slide is the references. Thank you.